September Masterclass. I'm your host, Zoe Etter, and today we're delighted to be joined by Dr. Laura Hughes, who is a Research Associate in the Roe Lab at the University of Cambridge. Before we start, a quick reminder to use the button on your screen to submit questions as we go along, and there'll be time to answer these at the end. If you'd like to re-watch any part of the talk, it will be available to watch on demand by visiting the MEG website, and will also be emailed to everyone who's registered. So without further delay, I'm pleased to hand over to Dr. Hughes to officially begin the masterclass. Thank you.
Thank you, Zoe. What I thought I would do for today is I'm going to just describe some of the research we do in Cambridge using MEG to understand more about neurodegenerative diseases. So specifically, the types of frontotemporal lobar degeneration, so they're types of dementia. And the primary goal of our lines of research is to establish whether MEG can be used as a platform for clinical trials. So we're firstly asking, can we measure the impact of any type of pharmacological intervention on the neurophysiological changes that we see in dementia? And secondly, and really importantly, do these changes then relate to behavioural symptoms, with the prospect of then improving these symptoms? So hopefully I'm going to show you some evidence today from a series of our studies of using pharmacological MEG with our participants who have dementia. Now, dementia is really an umbrella term for abnormal cognitive and behavioural changes with age that interfere with daily life, and they typically progress over time and contribute to a premature death. And there are many factors that contribute to the risk of developing dementia, which then means there are many, many targets for treatment and many ways to measure the outcome. So in the pathogenic cascade of dementia, oops, sorry, I should have slipped my slides. In the pathogenic cascade of dementia, MEG is uniquely positioned to measure the changes in neurophysiology. So it's also including changes to neural oscillations and changes in connectivity that occur in dementia. And these changes are downstream effects of disease on synaptic function and loss of neurotransmission. So to complement our MEG analyses, we can add in data from PET and spectroscopy to inform our analysis. And we can also use structural MRI to provide measures of brain atrophy, as well as obviously being useful for co-registration. So in this way, what we want to do is bring together multiple techniques to try and identify the mechanisms of disease and directly relate these to changes in behaviour and cognition and quality of life and survival, because they're kind of like the really key endpoints that you would want for a clinical trial. Now, if we want to intervene in this dementia cascade, pharmacological therapy might be a potential way to treat or to restore neurotransmission, and then consequently improve neurophysiology, which then could lead to changes in symptoms. So you can see there's probably several steps to this process. And by repurposing existing medications, we can investigate targets for treatment. So what we've been doing is using double-blind, placebo-controlled studies to directly measure changes in neurophysiology and behaviour, with the aim then to identify targets for treatments and markers of cognitive or behavioural restoration. Now, the drug studies that we've used have focused on participants who have behavioural variant frontotemporal dementia and progressive supranuclear palsy. And these are both degenerative diseases that come under the umbrella of frontotemporal lobar degeneration, mostly because they have frontal and temporal lobar degeneration. So it's very much named as the pathology occurs. And this is the most common form of dementia diagnosed in people under the age of 65. Alzheimer's obviously is the most common form of dementia, but usually diagnosed, and it gets more and more common as age progresses. And both of these diseases, FTD and PSP, result in changes in behavioural and personality. And we are here in our studies, we're focusing really on the neural mechanisms for apathy, disinhibition, and impulsivity, and the lack of insight that they have. These are key characteristics that present in clinic and that carers can say really affect and impact quality of life. So perhaps if we could find a symptomatic treatment for some of these symptoms, we might be improving quality of life, even perhaps if we're not really changing the course or the way that the pathology spreads throughout the brain. So one potentially treatable contributor to these behavioural changes is a significant loss of neurotransmission. Using MR spectroscopy, we've shown a depletion in the concentration of glutamate and GABA in the prefrontal cortex in our participants with FTLD, compared to our groups of age-matched controls. GABA and glutamate obviously are the major excitatory inhibitory neurotransmitters, and post-mortem studies have also shown similar depletion of neurotransmission. But obviously using MRS, we can look at this in vivo in our patients who are coming in to our clinics and people who are coming in and volunteering to take part in our research studies. And really importantly, we've shown that this loss of neurotransmission in these neurotransmitters correlates with behaviour. So those people who had lower concentrations of GABA, for example, were more impulsive on measures of response inhibition, and they also had higher scores on the impulsivity and lower scores on general cognition as well. So really demonstrating that this loss of neurotransmission really can impact cognition, and the loss of neurotransmitters impacts cognition and behaviour in our participant groups. So if behavioural impairments then are linked to the loss of neurotransmission, the question really remains, if we boost or increase neurotransmission, are we going to be able to improve symptoms? And this is really important before we want to set up costly and lengthy clinical trials. So we really want to be certain of a target for treatment. Clinical trials can take a long time, they tend to be longitudinal. Obviously they can be quite expensive as well, and you want to recruit more and more people into them. So for example, if you look at some of the clinical trials for Alzheimer's disease, you can see some of the early drugs back in the 90s, Aricept, for example, there's been very little progress on that until very, very recently. So it takes a very long time for clinical trials to come to a point where we've got an actual medication for treatment. So what we really ought to do then is find some targets for treatment, not just stabbing in the dark before we start our proper clinical trials. We want to get some endpoints in early. So the first step then really is to strengthen our understanding of how these changes in neurotransmission are going to manifest in measurable neurophysiological changes in vivo in people who can come into our clinics. And then secondly, we're going to ask, can we measure these changes that are induced by these pharmacological therapies so that we can understand the mechanisms of action? So before we even want to have a look at whether we can treat symptoms, we want to have a look at whether we can measure the effects of these drugs on our neurophysiology using MEG. So I'm going to discuss some evidence then that we find from three of our different MEG drug studies using GABA enhancement with a drug called Tiagabine, Zolpidem and glutamate using Memantine. So these are different types of ways of enhancing the GABA or the glutamate, and they tend to be very safe drugs, which is the primary reason that we've chosen these three. That they're very well used across the world, which means that we have a very well described symptoms and side effects of taking these drugs. So we know that we can minimise the risk in our patient groups, because that's the ultimate, as some of these kind of preclinical early trials, we really want to make sure that we're giving people safe medication and not to cause any unwanted side effects. So Tiagabine is usually used as an anti-seizure medication. Zolpidem is very widely used as a sleep medication, and Memantine has been used for a very long time in Alzheimer's disease. And they all have slightly different mechanisms of effects, especially Tiagabine and Zolpidem. So in our MEG, we run double-blind placebo-controlled studies, and we invite our participants in for 2 visits. Once they come in on the active drug, and once they come in on placebo. And these are 2 visits about a couple of weeks apart. And once they're in the MEG, they undertake a series of paradigms. So we have our traditional resting state, eyes closed paradigm. We use an auditory roving oddball paradigm. And we have various different kind of motor control, motor inhibition paradigms that we use as well to really tap into those symptoms that we're interested in motor inhibition, motor control. And from the MEG data then, I'm going to show you some of the power changes in the frequency spectrum in sensor space, and we also localize those to source space using beamformers. And then to examine the impact of disease and the drug on cortical networks, we've been using dynamic causal modelling, supplemented where we can with our individual covariates from spectroscopy and from PET when we've got those available. Not everybody who comes into MEG can also have a PET or have a 7T MRI with us for various reasons. Okay, so the very first step we wanted was to establish the effects of disease. So across most of our paradigms, as well as other studies as well from outside of our labs, we've shown this consistent loss of beta power in those with FTD and PSP. And we see this loss in the resting state, in the eyes closed resting state, with local efficiency reduced in the lower frequencies in the FTD and the PSP groups. And it's actually in this paper with Saba showed that this also differentiated these FTLD groups from our Alzheimer patient groups as well. And we've also shown this in our roving auditory audible paradigm, showing that the relative modulation of beta power to the deviant tone was reduced, particularly in people with PSP. And critically, we're coming to our motor paradigms. So we also show that beta power, the beta power modulations that you would expect with movement. So you would expect a beta desynchronization with the onset and offset of a movement, also with the planning of a movement, the preparation of a movement. And this was impaired in our patient groups. So we've got different paradigms, a go paradigm and a stop signal paradigm. And if we look at the go trials there on the top row, the controls, you can see you have a nice blue beta desynchronization, blue blob, and then the red blob, you've got the resynchronization as well. And this is really impaired in the patient groups. In those with BVFTD, they really didn't have the same extent of beta power modulation, which means obviously also don't have the rebound. And again, in the stop paradigm, so these are just the go trials on the top row, the controls compared to the FTD and the PSP groups, again, the patient groups are showing a loss of this modulation. And also we can look at this with motor inhibition. So motor inhibition also will induce a beta desynchronization, particularly in a no-go or stop trial, because that's a kind of a prepotent response, an expected response that has to be actively inhibited, which means in the controls you get a beta desynchronization followed by a rebound, even though you don't come up with a button press in those trials. So these are all successfully inhibited trials. Those with BVFTD, again, they just don't show this beta desynchronization. And those with PSP as well, very little desynchronization to those successfully inhibited trials. Now, really importantly, we kind of correlated this with actual behaviour, with our clinical measures in the clinic of behavioural disinhibition. And what we showed was that in those with BVFTD, the change or the modulation in beta power was less in those who are most disinhibited, which suggests then that if the people who are very, very impulsive, who are very kind of on the edge to press a button, to go, to move, I mean, if they had any beta desynchronization, they were not able to inhibit their responses. So they're only able to successfully inhibit a response when there was very little beta desynchronization, really suggesting then a tight link between these modulations of beta power and behaviour, as well as some of the clinical characteristics that we see on our paper, standard paper and pencil tests. So given then that we've got this depletion of GABA and glutamate, the reduction in this beta modulation that we see across different tasks, the link to behaviour and behavioural symptoms of impulsivity, we really want to ask, can we restore beta pharmacologically and change task behaviour? So at this point, we're not really looking at an actual treatment for symptoms. As soon as we start looking for a treatment for symptoms, it becomes a clinical trial. So a clinical trial is really defined by not what you're actually doing, but what your endpoints and what your goals are. So if we used a drug and we looked and we said hypothesized that we were looking for an improvement in behavioural symptoms of the disease, then this could be interpreted as an actual clinical trial, because we're looking at the effects of drug on behaviour, of kind of relevant clinical behaviour. So instead, rather than kind of having to kind of frame our whole studies as a clinical trial, what we just really want to start with is, can we restore beta pharmacologically and look at whether we can improve task behaviour, and then perhaps link that task behaviour onto clinical characteristics later. And it's just a way of having a kind of a fairly straightforward, simple, non-clinical, non-CTEM trial using our MEG. So there are many prior studies examining the pharmacological effects of GABA and glutamate, using very kind of a number of different types of typical medications that have been shown to have some symptomatic treatments in patients, as well as having MEG effects in health. So we've devised a few studies there to try and bring all of this evidence together. So to start with, we've tested 2 cohorts of participants on a novel motor learning paradigm to examine how people learn to adapt their motor behaviour over time and how they respond to feedback. Can they adapt behaviour? And perhaps that then is key to looking at the treatment for impulsivity. If you've got a way of controlling behaviour and improving your behavioural learning over trial, then perhaps it's a way to improve impulsivity. So the participant's task was simply to move a car in the shape of move a queue in the shape of a car into a target kind of parking space, and they did this using a joystick, just moving the box actually from right to left. So as we've shown before, in this, again, this is a different cohort of participants. We've shown that that successful movements in the patients again resulted in this loss of beta modulation. And this was source localised to regions that you would expect, motor and premotor regions. And this was similar across our 2 cohorts. Cohort 1 is using Tiagabine and cohort 2 is using Memantine. Behaviourally, we showed that we're interested in learning over trials, so looking at the error rates trial by trial and seeing how that changes. With controls, as we would have expected, there is a slope of learning, so people do get better over trial at moving this cue into the target box. But the patients didn't show the same level of learning, so they didn't show the same level of modulation of the task over trials, particularly those with PSP. So in the behavioural box there, you can see that those with PSP, the red lines, are actually not getting better over time. They're actually probably getting worse, if anything, especially that top line up there. And this was linked to changes, again, to this impaired modulation of beta desynchronization. And this was the same across the 2 cohorts as well. So you can see there's very comparable effects of the Tiagabine and the Memantine study. And again, this was linked to our cognitive score. So people who had lower cognitive scores, as you would imagine, were worse at the task. So it does again link into some of our kind of cognitive measures of our participants. So coming on then onto the drug effects, what we're showing on Tiagabine to start with, that learning did improve over trial for the patients when they were taking Tiagabine. So Tiagabine compared to placebo showed an improvement in their learning over trials. So you can see there we've plotted the controls, the FTD and the PSP groups, and you can see that the slope of learning for the controls is actually very little difference between the Tiagabine and the placebo sessions, but with the FTD and especially the PSP groups, you can see an improvement, a steeper slope of learning when they're on Tiagabine, when they've taken that medication. And also critically, we showed that this slope of learning was related to one of the cognitive scores of frontal functions, the IMICO. So that those who had a greater slope of learning on drug or had a greater change on drug were those who had higher cognitive scores. So perhaps those, again, perhaps is a way of stratifying people to show that those who were better on the drug, or those who showed improvement on the drug in their task behaviour, were those who had higher cognitive scores. And using the beamformer analysis, looking at the spectral power to start with, again, we can show that, as previous studies have shown, that over the course of trials, we show an increase in the beta power modulation, so an increase in the ERD and ERS patterns. And this was enhanced on tiagabine, particularly for the patient groups. Again, there was very little effect in the healthy control groups, but in those with FTLD, tiagabine enhanced this modulation over trials. So perhaps then an explanation of why the patient groups were benefiting on the drug was perhaps because the tiagabine is enhancing this beta modulation. But interestingly, there was a difference between those with PSP and those with FTD in the way that the beta power was modulated. So in those with behavioural variant FTD, beta power was enhanced, it increased, and those with PSP, the beta desynchronization especially, was enhanced. So you get greater desynchronization in the PSP and greater beta power, so less desynchronization in those with the behavioural variant FTD. So again, maybe perhaps an explanation of a way or mechanism of how behavioural control is being enhanced. Perhaps in those with PSP, if they can't desynchronize enough, it becomes very difficult to start the movement. And those with FTD who are on the verge, behavioural variant FTD, who are on the verge of moving all the time, perhaps an elevated level of beta power, which kind of stops the beta desynchronization, would enhance movement, enhance that behavioural control. And using our beamformer analysis, we localised the sources of the effects of drug into prefrontal cortex. So beta power was reduced in the prefrontal cortex on the placebo sessions, and this was enhanced by tiagabine. So again, not just showing, I was showing a kind of a mechanism of how beta is affected by drug, but also where in the prefrontal cortex, obviously a very key region in a frontotemporal dementia, where pathology is at the strongest. So was MEG also sensitive to glutamate modulation? So using Memantine. So again, it's exactly the same paradigm, but a different cohort of patients and controls. And again, all the participants showed learning over trials, particularly the healthy controls, although the patient groups didn't show much learning over trials on placebo. And on drug, it was only those with BVFTD, the behavioural variant FTD group, who showed an improvement of learning over trials on Memantine. And again, this task performance was related to our cognitive score. So the change in performance on Memantine, that perhaps improvement of performance on Memantine, was related to clinical characteristics in again the frontal measure of frontal function. So those with the highest frontal function had the greatest change in response to drug. And we also had measures from the MRS with this cohort, again showing that those with the highest levels of glutamate using the MRS showed the greatest change in learning. So perhaps those who could benefit the most from taking a tablet like Memantine were those who had the highest cognitive scores, but also had higher levels of intrinsic glutamate, higher concentration of intrinsic glutamate. And using the beamformer analysis, again, we looked at this learning interaction on drug, so placebo versus the Memantine. And again, it was, as we would expect, it impacted the change in the beta, so the beta modulation during the movement. But again, differentially. So really interesting that those with PSP responded differently to those who had BVFTD. Now remember that those who had PSP, as you can see in the top left plot, they didn't show any improvement in learning over trial. So that's the red lines, the red and the pink lines are those with PSP. And what happened on Memantine was that actually Memantine showed an effect of increasing beta power. So perhaps reducing the beta modulation during movement. We might expect that would prevent movement or hinder movement in some way. So perhaps this is a way that Memantine actually impaired the patients from learning and being able to modulate their behaviour over trials. Whereas those with FTD, it actually enhanced the beta desynchronization. So again, facilitating movement, so perhaps that they again showed more learning or more improvement over trials because they were able to modulate their beta power. And again, we've source localized this, and this time again we show similar regions of beta reduction in our patient groups, and that the interaction with Memantine, so looking at the placebo versus the Memantine source power, was in the pre-SMA. So clearly a region that's really important for movement and movement control. So by enhancing beta power in this region, when you need a beta desynchronization, is possibly prevent the way that those with PSP are unable to improve their behaviour over trials. Okay, so that's our two drugs compared as same task side by side. But what we really again want to understand moving forward then is the mechanism of action. So although these drugs are nice kind of demonstrators of how we can measure neurophysiological changes, they perhaps might not be the best medications in order to treat symptoms, to improve, say, beta power, particularly Memantine. So the next step is just really try and understand a little bit more about the mechanisms of action. And we did this using dynamic causal modelling. Okay, so in this series of studies, the next series of studies, again taking the same data from different tasks, but from the same cohorts, and we've tried to characterise the relationship between the neurophysiology and neurotransmission. So using DCM, dynamic causal modelling, we select a region of interest. So in this example, we've used the right IFG, a region that's involved, that's really key in the pathology of FTLD, but also a really key region for response control, response inhibition. And what we do is we create a model that represents the cell populations within a cortical column of the IFG. So it includes nodes representing different cell populations, such as the superficial and deep pyramidal cells, stellate cells, and inhibitory interneurons. And it also models the properties of the connections, including conductance dynamics, ion dynamics of NMDA, GABA, and AMPA. And in this model, we also include individual baseline measures of GABA and glutamate concentration from our spectroscopy. And then we can fit the data to the model in order to get the best fit. And we can tweak the model as we go to try and improve that fit by including extra connections or removing some of the connections. So in this particular example, we test whether the connection strengths are influenced by the spectroscopy measures. And from this data set, we showed that the GABA concentration from the MRS influences the local recurrent inhibitory intrinsic connectivity in the deep and the superficial cortical layers. So the GABA measures, the GABA concentration, really changed the dynamics of these inhibitory intrinsic connections. And the glutamate was found to influence the excitatory connections between the superficial and the deep layers, as well as connections from the superficial to the inhibitory interneurons. So this was really a demonstration of proof of principle that we can model our data using these cortical microcircuits, and we can provide results that we might expect with the literature and our knowledge of microcircuit connectivity, so that the GABA is going to influence the inhibitory connections and glutamate the excitatory connections. So it's a really nice proof that or demonstration that these models can work. And then what we want to do is take them into our patient populations as well and look at the effects of drug. So in these models, again, similar models, but this time we've used our auditory audible data rather than the resting state data. And again, as well as incorporating the spectroscopy, we're also now comparing our 2 sessions on placebo and on Tiagabine. In the patient groups, we revealed that the GABA deficit manifests as aberrant deep inhibitory intrinsic connections, such that those with the lowest GABA concentration had the lowest baseline inhibition in these deep layers. And the effects of Tiagabine was that it really depended on the GABA concentration. So again, those who had higher GABA concentration, measured by the MOS, had increased baseline inhibition by Tiagabine. So it was this in these deep inhibitory cells that the Tiagabine was having its effect, but really again stratifying our patient groups, showing that it's really those who have the highest concentrations are going to benefit more from Tiagabine. And there's also an interaction between our patient groups. So in the previous studies, again, I showed there was actually a slight difference in the way that the drugs and the medications affect those who have BVFTD and those who have PSP. And in this model, it showed that the site of interaction was at the stellate cells. And these are layer 4 cells that mediate rhythmic firing patterns within the microcircuit. And this is where the FTD differed from the PSP group. So perhaps in future research, we might kind of look in again at some of the behavioural disinhibition from the patients groups and seeing whether beta power is affected at this kind of level, layer 4. So really, in summary, now we can use these models to identify deficits in patients and the mechanisms of action of the drug. But critically, really, they're showing this real importance of kind of trying to stratify patient groups to show who's going to benefit from the drug, because perhaps if we do a clinical trial and give the drug to a whole group of people, we might only see effects in some people. So we really want to know, if we're going to target people, who can we help the most with different types of medications. So if we come back then to our kind of pathogenic cascade of dementia, I hope then I've shown that MEG can be useful not only in determining a potential target for our focused symptomatic treatment, but also showing that MEG is sensitive to pharmacological challenges, and then revealing how the mechanism of treatment might work then at that neural circuit level. And if we want to improve specificity, we want to identify those who are going to respond best to treatment using a holistic approach, trying to bring together not just our MEG analysis, but bringing in our spectroscopy and perhaps our PET data as well. Okay, I would like to thank you for listening, and obviously thank you to all of our volunteers. We have a lot of people who come into the clinics who very readily volunteer kindly and give up their days to come and take part in our research study. And obviously I couldn't do all of this without a huge team behind it, and I've talked about a lot of work from other members of our lab group as well. And I'd also like to thank you very much for listening. And if you have any questions, please let me know.
Thank you very much for sharing your work, Dr. Hughes. We now have questions, so please feel free to submit them as we go along. So let's start with the first one. How far away are we from using MEG in clinical trials for dementia?
Thank you. Yes, where are we at with clinical trials? It's a really interesting question to try and look at. I think it is already being used in different pharmacological studies. So some of those are going to be types of clinical trials. I kind of think what we're trying to look at is, can we facilitate these very broad kind of later phase clinical trials for pharmacological treatments? So there's a lot of trials looking at how different treatments can impact very specific types of task behaviour. But again, we need to kind of look at how far away are we from using that to treat really important endpoints of disease. So we want to improve quality of life. We want to, even if we can't look at perhaps changing the pathology or the the spread of the disease itself. If we can improve quality of life, then that will hugely benefit a lot of people. So I think we're very close. I think we in our group are really looking at whether we can start some clinical trials. Clinical trials tend to be very costly. And if we're looking at clinical trials as well, we might want to use more sites. So we might not just want to use our Cambridge MEG system, which tends to be very busy, so you're kind of always fighting for space to try and access it. You kind of want to perhaps, and also there's a smaller cohort of people who are able to travel into Cambridge. We'd probably want to use multiple sites across the country, perhaps across Europe. And then there's all those difficulties to try and bring in as well. So we obviously have a way to go before we look at how comparable sites are and getting all the sites on board and who would be able to be kind of have to go through all the red tape of starting a clinical trial there. So there's a few kind of steps to go, but there are a lot of multi-site studies in place already, just general population-based studies as well. So I think it's not too far a step, or not too much of a big step to go further and actually use it in a clinical trial. And really, as I said during the talk, clinical trials really defined not by what you're doing, but what your question is, what your hypothesis is. So perhaps there's already kind of a number of potential clinical trials already running, just with perhaps a change in the focus of the endpoints.
And following on from that, what do you see as the major blocks to using MEG in clinical trials?
Yes, probably. I think it's just, like with most studies, forming strong collaborations, starting up and getting everyone together and on board with which tasks you're going to use. What are your endpoints going to be? With MEG, you can probably, as we all know when we're analysing our data, there are many ways to look at our data. There's many results that we can get. So if we want an endpoint for our clinical trial, usually we only want a handful. We don't want to look at, have a number, but we need to have a specific number of endpoints. We don't just want a general, let's go and have a look at our data and see what we find kind of approach. So it's trying to understand what really would be the endpoints if we're looking at a clinical trial to improve symptoms or quality of life. What neurophysiological endpoints can we measure that's going to tie directly to those clinical endpoints? So I think that's quite a difficult question to answer. And I think that's possibly one of the roadblocks at the moment, is like, what do we do? So if we had the pharmacies come to us and say, okay, we're going to run a clinical trial with MEG, what should we measure? And at the moment, I obviously would say, well, we've shown quite a lot of changes in beta power, and that beta power can be sensitive to medication. So that's possibly an endpoint. But even then, we're narrowing that down. Or they say, well, could we look at? Could we look at, the extent of the beta desynchronization at, within time points or windows of the task. So you can see that you kind of got to really narrow it down and say, well, these are our endpoints, and be very specific before you run the trial. And I think a lot of our MEG data tends to be not that our hypotheses aren't specific, but I think for clinical trials they need to be really link our MEG endpoints with our clinical endpoints, and that's probably one of the tricky things.
And could you expand any more on what endpoints you think that we should be expecting from one of the trials?
Well, I think the first step, particularly for changes in neurophysiology, and again, kind of going back to looking at that cascade of dementia, what neurophysiology can tell us is a little bit more downstream from some of those pathological changes. So we're not going to be looking at changes in the early stages of that cascade. So we're not looking at, obviously we're not going to be able to change genetics using, well, I imagine at the moment, using this style of study, we're not looking at changing the genetics or changing or removing some of the pathology that builds up. What we're looking at is changing the neurotransmission and improving symptomatic treatments. So there's more. Obviously, I've talked a lot about GABA and glutamate, the major kind of inhibitory and excitatory neurotransmitters, but obviously there's other trials again looking at, for example, serotonin or noradrenaline as well, which are also very impaired in our patient groups. So I think there's this, I've tried to narrow it down a little bit with some of our research, but there's a much broader way of looking at it. So to be a bit more specific and expand on those endpoints, I think it really would depend. I think we have to start with the patients and ask, those who have the FTD in their, or PSP in their carers, for example, what would they like to see improved? And we quite often have these kind of PPI groups to kind of discuss what are the important things, because sometimes you might think one symptom is impacting care or carer and patient quality of life, but actually they might say, well, actually if they weren't quite so disinhibited and impulsive, it would be easier to kind of put everything in place to look after the person and to enjoy good quality of life together. So I think that's probably one of the first steps, is asking keeping in touch with our patients and our carers, asking them what do they think, what would they like to be improved the most, and then taking that and looking back at what we can change neurophysiologically and how we can link all of that together.
That sounds really important. Let's see if we've got any other questions. It doesn't look like it, unless anyone wants to ask one in the last few minutes. I think we'll leave it there for today then.
Oh, lovely. Well, my email address is there. If anyone has any questions, feel free to get in touch.
So thank you so much, Dr. Hughes, for a fascinating masterclass presentation. And thank you to all the attendees for joining us today. We hope to see you all again soon. Goodbye.